is with us this evening to discuss dopamine, how it affects us, really, it just affects everything in our lives or what we do, what we think. And just to tell you a little bit about David, he is certified physician assistant in psychiatry down in Morehead City, North Carolina for Port Health Services. And he's also physician assistant urgent and primary care in the current Carolinas Center for Surgery down in Morehead as well. And last but not least, he is a physician assistant in hospitalist intensivist. I may not have explained all those well, but also at current Carteret Healthcare in Morehead City. So I imagine he's quite busy. So we are so happy to have you here on this very wet evening. I don't know what everybody's weather is, but in Virginia Beach, it has been pouring all day. How about where you are?
Yes, that's drenched. Yeah,
All
yeah,
day.
all day.
Yeah. So why don't you tell us first of all, how did you get into your field? Did you know just from the get-go that you were going to be a PA?
No, there was a substantial amount of back and forth. Most physician assistants end up starting in a different field. I think the average age of acceptance, I went to EVMS. I think our class, the average age was 31. Most of us have about 5,000 clinical hours prior. Mine was in infectious disease and epidemiology, ethnic health disparities, so rural communities, diabetes management, comorbidities, and then did some time with economics, did some forecasting, did some landscaping, did every job in between.
Nice.
And then, yeah, during PA school, the psychiatry, just things kind of click for you. And I
Hmm.
got to meet Mary, who you're stepping in for, you're fantastic. But she was a very good friend, and then did some rounds with another professor and David Spiegel up there, who's brilliant. And
Oh, brilliant man.
yeah, psychiatry ended up being quite intricate for a PA. There's a lot of underlying things that not people were missing, but at least the people I studied with, they looked into that it can become as holistic as you want.
Mhm.
So, is this worse because of sleep? Is this worse because of vitamins? Is this worse because of this? And it gets, you could take it as deep as you want. And so, yeah, I absolutely fell in love with it. And then, after starting in psychiatry, I just wanted to make sure, and I don't, the other jobs, I don't moonlight them. It's been about 6 months. I did pull one urgent care shift, but that's just to make sure I still remember how to fix broken bones and stitch up major cuts and stop
Yeah.
bleeding. And
Keep your feet in the water. Yeah.
yeah, just to make sure I
So
still remember how to do it. And yeah, PA
the
school prepares you.
psychiatry is the pull.
Yeah, psychiatrist the pool, 100%,
100%.
all the time.
So Mary Crutchfield, for those of you who don't know, she is a psychiatric nurse practitioner who is on the board of NAMI Coastal, which we are very proud to have her on the board. She's such a good voice and just gives us great advice and guidance. So we miss her this evening, but so glad you could join us. Glad you guys made friends. And so when you all were figuring out the topic for tonight, dopamine.
Yeah.
Why dopamine?
Well, she wanted to talk about the thoughts about this destigmatizing addiction, and I've given multiple talks on addiction, and I am a psychiatric. The clinic I work in is also addiction medicine nonprofit. So a lot of the talks that we, or as a visiting lecturer, it's often geared towards heroin, alcohol. And then the other questions come in. What about binge eating? What about screen time? What about, well, it's all dopamine. The dopamine reward pathway is everything. We've all heard the term runner's high.
Yeah.
That's a dopamine flux.
Not me personally. I haven't experienced it, but I've heard about it.
No, I ran for like a year maybe. I'm good without it. No, but the point is dopamine reward pathway is a part of everything we do or choose to do, and it's fantastic. And it also can be a bear. Yeah.
Yeah. So how can, that is one thing as I was looking at, I never thought about dope having at least me, layperson, I only hear about the positives of dopamine. And so I
Right.
never even thought about too much dopamine being a problem. So how is that possible?
Well, just on a medical, standpoint, pulling things back, dopamine is one of the main neurotransmitters that's affected with certain disorders such as Parkinson's. Um, and there's a lot of neurotransmission that happens in the brain that ends up being dopaminergic. But when we're talking about the dopamine reward pathway, the brain floods with, that happy hormone for multiple reasons. Sunsets, I often tell my patients that, a sunset, a walk where you're breathing a little bit happier, a baby's laugh, a movie that makes you laugh, intimacy, all those things. And there's something we used to say, like when a good thing becomes like a God thing, not to make it like a spiritual thing, but we put it up on a pedestal. Sometimes there's that drop when something's ripped from us. And so, our body's always looking for some sort of balance. So if you take, for instance, someone that runs all the time and they get an injury and they're out for 3 or 4 weeks,
Hmm.
they have some what we'd consider like, maybe an adjustment disorder, low mood, low drive, that dopamine, that fix they had, that thing that
Can't
they
get.
loved is ripped from them. So that can be, you could tailor that to any situation. And there's other neurotransmitters at play at all times, tons of them. You can get into that a little more details with, later attention deficit disorders, norepinephrine, but they partner together with dopamine. They
Yeah.
they go hand in hand, and so yeah, that is a big part of it. When we eat food that tastes really good, dopamine floods the
Ah,
brain. Yeah,
yeah. And so that if I'm so that would be also what is keeping somebody, if they do have unhealthy eating habits, continuing with them because of the dopamine release?
oh, possibly. So unhealthy, yes, yes and no. So no, meaning it's like it's more detailed than that. I think that the real question is the why. So unhealthy eating habits might be something that's a learned behavior. That's where the public health side comes in. If that's all you've known, and
Mhm.
that's where all you could afford, and then we rip certain things away. Or if it's stress eating, there's certain things that release dopamine. I mean, caffeine does a great job. Naturally occurring caffeine and chocolate does a good job.
That's my
But yeah, yeah. Um, but when we end up moving towards like what we consider unhealthy eating habits, we'd have to distinguish between the one's ability to make that choice versus a binge eating disorder, which is a clinically a diagnosable disorder. Um, and then there's also like the
but what would
impulsivity.
be so then how would dopamine, how does that play in the, diagnosable, the binge eating disorder?
Sure. So binge eating disorder would be that kind of a compulsion to eat excessively and binge past the point of being full,
Mhm.
almost to the point of not, I wouldn't say grotesque, but you possibly nauseous, both metaphorically, like I'm nauseous with how much I've eaten, but also physically uncomfortable. And there is a flood of that dopamine, that reward from that. It does feel like an urge. Patients will describe it as like a numb feeling that they feel when they eat substantial large amounts, like they at a rapid pace, they do feel this weight. And then it comes with a drop afterwards, where it's a sense of disgust and a sense of being uncomfortable with that. It does kind of give a quick fix and then a drop as well that can be, um, it's all about the impairment of life, that impaired functionality of what one can do, what one desires to do, and what kind of impairment it leaves you with. And that moves into the other eating disorders. Do we binge then purge, or do we then restrict it? They don't always go hand in hand, but they can.
Okay, but it's not, dopamine isn't. it is a factor in it, but it's not the only factor that's at play. Is that right?
It's not. In the world of psychiatry, we like to think we're just treating the binging disorder. What I like to do, and what my colleagues often do, is we do like to say why. I mean, we are a nonprofit, so if we don't have a primary care and if things haven't been checked in a while, there are some other factors. Why are we so voraciously hungry all the time? Are we tired? Are we very sad? And it does make us happy, so we binge eat. Yes. Does your glucose also bottom out? Does anybody in your family have diabetes? Are you pre-diabetic, or do you have hypoglycemia where your blood sugar drops? And you have to eat all the time. When you eat, your body feels better because your blood sugar goes back up, but your mind also feels better. But you
Yeah.
can't lose weight because you have to eat this much. So then we kind of were like, all right, so we can do labs. Let's coordinate with primary care. Let's coordinate with health departments to try to figure out, like,
The
maybe
root
this is a medical thing that you've found a way around, but yet you're still tired and you have low drive, you're labile, flattened affect, don't want to get out of bed. This makes you feel good for a quick fix. It's the same kind of concept when we talk about addictive substances. Like, for instance, I'll be taboo to say this: alcohol and heroin, fantastic antidepressants for about 20 minutes,
yes. And
and then
then,
they drop out.
but
So
then you
what's
want
the
to keep.
so what's the underlying cause? What is the underlying cause? How long has the underlying cause been there? Is it trauma
But
based? Is it
then
a
when do you
trauma?
separate it? When do you separate it then from addiction? If you have the root cause, when does it cross over into addiction?
Yeah, so I think there's the addictive side, which we're talking about, like a physiological tolerance versus like where someone says, "Hey, I do this for so long, but if I stop," so the binge eating example is not great for that. Um, but if we had to make that jump, hypothetically, we could say binge eating has done really well for my mood, but then I drop and I also feel very shaky. Well, that's kind of a clue. Like, why do you feel shaky? Is your blood sugar bottoming out? So maybe there is a food addiction in the brain for the dopamine part, but also, like, what's happening with the blood sugar when we move into substances like alcohol, heroin, um, pick anything really. But that nicotine, fantastic for regulating that dopamine. But when it does drop out, what's the physiological repercussion? So that wouldn't be the same as binge eating. That wouldn't be the shake hypoglycemia. That would be a tolerance in the brain where, when those are removed, we have severe physiological reactions. And that's when we start to wonder, okay, so this thing worked for a little bit while we sought after this. It became a decent thing to let's say, like socially drinking, not bashing that at all. And now it's drinking regularly because when I'm in public, I get anxious around lots of people. Tolerance builds up. Now we remove the alcohol way to function at work, and I have headaches, I have sweats, I have shaking and trembling. That's a physiological, it's a mechanical, biological, physiological. From here down, you have symptoms that are like, okay, now the body requires more of it,
Oh,
or
yeah.
we withdraw from it.
So, so I remember one of my sons admitting that for him, he did need the alcohol. Otherwise, at parties, he was very anxious. And so you, so technically that was a couple years ago. If he's watching, maybe he doesn't even know which son I'm referring to. But so technically that might not even be an addiction, because as a parent, I'm like, no, this can't be happening. But it doesn't necessarily equate to an addiction. It's not a good habit to develop. I would like for that not to have happened. You know what I'm saying?
Sure. Yeah, I think it's also, yeah, and that could also be culturally dependent. I mean, I know that
Yeah.
drinking wine at every meal in different parts of Europe is very common. But when we use it to fix something that we perceive as highly stressful, and we aren't working on the underlying root cause. Now, a lot of people do not have access to mental health care.
Yeah.
And that's
Learning
hopefully
coping
hope
strategies. Yeah.
hopefully we're changing that and we're doing our very best. Or they're not aware. So without getting too far into like DSM criteria of diagnostics, there's
Mhm.
alcohol misuse, there's binge drinking, there's alcohol dependency. So it kind of teases out.
Categories.
That would be an unspecified misuse kind of binge drinking, but it's not to the point where the dependent part where we take that away and we can't function at work. Because if you meet someone that has an alcohol addiction, an alcohol use disorder,
Mhm.
you may never even know. Fully functional throughout the day, no slurring, no falling, nothing, and has to maintain small amounts of alcohol throughout the day so the brain does not have withdrawal. And alcohol withdrawal looks very similar to, and it can look as severe or similar to a seizure disorder.
Wow.
So
Just
that,
the
yeah,
withdrawal.
so when we
That is
find,
why in the hospital, if someone is an alcoholic, they still
yes,
need to prescribe, I forget, don't they need to prescribe like a drink or something for patients?
yes, did I freeze?
You did freeze.
I did not mean to freeze. There we go.
Ah, you're
So
back.
so yes, there's two different situations. So I've done work in the past where it's been in remote places. We've done work in other countries, and you look at someone's ability to desire to not want to drink, and they're not ready. It's not going to happen. There aren't the availability. The resources aren't available. The only thing that is available is alcohol. Okay. So natural disasters. Do we have things to detox someone appropriately and then move and set them up for success? No. This train wreck of a tsunami just came through. Emergency rooms, things like that will stock alcohol to make sure that doesn't happen. But typically we do use another medication that works on the brain, the same receptors in the brain, GABA glutamate, to
Yeah.
regulate the withdrawal from that alcohol, so that people will not seize, because seizures can happen with that particular disorder.
Okay.
Yeah.
And does dopamine, is it also, so I heard once, let's say someone was addicted to heroin and they quit, they haven't, used in a couple years, and they can be driving down the street and pull up to a stoplight next to the place, maybe the corner where they used to buy their heroin, and they can start salivating and everything. Is that dopamine, or is that just other things happening in the brain?
No, this is when it gets a little complicated, and I didn't want to. I think the brain is absolutely fascinating. So
Yeah.
I don't want to like make this med school 101 or PA school 101.
Okay.
So we'll just skim over it and
Okay.
just say the summary is lots are involved. So like the dopamine reward pathway or dopaminergic reward pathway involves what we call like the mesolimbic system. It involves the midbrain, the dopamine neurons of the midbrain, and involves what we call the ventral tegmental area, which is the VTA in the striatum, the prefrontal cortex of the brain, the amygdala, the hippocampus, and the limbic system. So the dopamine
Got it.
reward path
Got
just in a long. So what happens is the reward pathway goes around everywhere with our decision making, our ability to even to a point of where our heart rate and blood pressure drops, things like that. Think
Okay.
about deep breathing and grounding techniques. We end up getting calmer. We get a little euphoric, even if you do like holotropic breathing, which I'm not recommending anyone do out of nowhere. Um, but
I've heard about
those,
that.
yeah, those sort of things, right? What happens physiologically? You know, our heart rate drops. We feel more comfortable. Our respirations control. Our body relaxes. Our blood pressure drops. So, long story short, the dopamine reward pathway, it helps with it involves four major parts of the brain. And so that's why when we pull things away, we get a slew of side effects or symptoms.
Yeah.
Um, and sometimes it's easier to understand these things when you work backwards. Like when we take it away, what physiologically happens. And then you're like, oh, so when we use it, this must be helping with this. So sweaty, anxious, fast heartbeat, difficulty sleeping, depressed mood. You're like, difficulty like making judgment, but also with spatial awareness, like where I am in time, like okay, so when I do use this, I feel calmer. I can converse with others better. I feel like I can operate better, like motor function, all this stuff. It's so if you look at what we remove, what happens when we remove and like reverse it, you're like, oh, okay.
That makes sense. Yeah.
Yeah, think of it backwards is a little bit easier. And it's easier for me as well when I learned it. I'm like, that's a lot of big words. Let's work backwards.
Let's work
Yeah,
backwards.
yeah,
I like it.
yeah.
So, so someone did ask, someone who registered asked, what is the intersection of ADHD brains and the dopamine pathway?
It's beautiful. Absolutely lovely. So I would hypothesize that it moves in two different areas, but let's just go ahead and talk about the general. So attention deficit, I absolutely love. I saw it on a Instagram story about Dr. Amen with Amen Clinics does these fantastic studies with the brain. It's not a lack of knowledge. It's not a lack of ability to produce that knowledge. It is uh, for the lack of a better way to describe it, a signaling conduction issue with norepinephrine. And norepinephrine, I just think of them as like dopamine and norepinephrine are like buddies. They're like holding hands, kind of like when we used to play like Red Rover. Yeah, that's dopamine and norepinephrine. Um, so once again, if you think about it backwards, one is what we experience when we can't focus well with ADHD, or maybe it's the hyperactive inattentive type, the combined presentation. And that is that kind of frustration and letdown with some patients will tell me the best analogy I get is you have about 10 things you're going to do in your head and you have them in perfect order. And then you go to execute them, put your foot forward, and you mess them all up in order. And you actually left your keys over there. And everything was perfect. But then when we went to go do them, nothing that we planned in our head happened. Or I had a perfect conversation planned and I was listening to someone very intently, like a spouse or a friend. And I tried to focus. And then when I went to go say, when I put in order what they said and how I was going to respond, what I tried to say, nothing came out. So physiologically, the dopamine and norepinephrine go together as friends. But then we ask, what happens? The questions I ask is, what happens when we can't accomplish the things we want to accomplish
Mhm.
with ADHD? The opposite of that dopamine reward, correct?
Yeah.
We have self-doubt. We have this influx of anxiety that comes with the inability to maintain focus. And it ends up being very frustrating, inability to complete tasks. And so it gets this negative feedback where things get worse. Take a small child. They absolutely love playing with their friends. They are flourishing. Like my daughter is in a nature school outside. She's quite squirrely, and I love it because I don't use a squirrely word derogatorily. In PA school, one of my favorite professors put a sign on one of her chairs that said "squirrel chair for David," and where I could spin and talk at the same time. Um,
Tells me a lot.
yeah, but she really has a hard time with reading, loves math. When she starts the reading comprehension, about halfway through the paragraph, doesn't know where we started or where we began, doesn't know what's happening. Her response, and adults can agree with this, so I like to take it back to a child's response because children are extremely honest. I hate myself. I'm the worst kid ever. I hate reading. I'll never learn to read.
Gosh. Yeah.
That's real. And
Yeah,
adults, we dress it up a little
completely.
bit more, but that's really what we feel. And when we try to regulate attention deficit disorder and regulate that norepinephrine, that dopamine that goes with it is what is really what we're treating on a pharmacological scale. But the impact we also get is that there is some self-confidence that builds up. And the muscle that we've been using, metaphorically, the brain, the muscle we've been using is working the way we want it to work. And pride in ourselves and our work and less anxiety, these things build up over time. That doesn't mean we have to be on medications forever. There's a great website for tons of people, Attitude Magazine, even for adults, attitudemag.com. There's
AttitudeMag.com.
so many things that talk about the dopamine reward pathway for ADHD in that specifically, Like for instance, my daughter does not get she can get strawberry popsicles all day long, but it's going to be strawberry and water based, like 3 ingredients. Red dye, don't ask me that one. I haven't gone down that. But red dye and ADHD, not a friend. Caffeine slows down neurotransmitters, so caffeine and ADHD are a great friend until you get heart palpitations because you drank so much caffeine.
And then when the caffeine wears off. Now,
Then there's
technically, couldn't you, if when she's reading and she's having troubles, couldn't you try to stimulate like a natural dopamine release?
That's it. So that's one of the things I absolutely love when working with ADHD children is there's a few things generationally, and this is the public health side
I wish
coming
I'd
again.
known this. I wish
Yeah,
I'd
I'm
known
not.
this because we've got ADHD in my
Oh
family.
yeah, oh
Yeah,
yeah, us too. And
and
but we
it's my
don't.
side.
And I'm not bashing any generation that came before us, but there's a few things that children, in my opinion, and adults even, I give all adults a pass. Um,
Thank you.
Look at me when I'm talking to you. Come on, like that's hard. You know what I mean? So, for instance, when I was studying medicine, you would give me a 2-hour lecture from a brilliant, brilliant doctor. Nope, 20 minutes, I'm gone. So the adult brain and the child brain, it doesn't matter to me. What I've done with my little one is I said, honey, you want to have a big girl conversation? Yes. We're going to do something called chunking. Chunking? Yeah, look, we're going to set a timer for you. It's 3 minutes. Well, this is what you're going to learn. We're going to stop. We're going to come back. We're going to talk about what we learned. We're going to do another 3 minutes, consolidate, chunk, chunk, chunk. And in between, you can get up, get your wiggles out, move around. Another thing good for dopamine, and I tell this for anxious patients and ADHD patients, depressed patients across the board, physical activity. There's enough studies, and there's a huge argument online between two of my favorite biochemists, biophysicists. What comes first, medication or exercise? The answer is yes.
Okay.
It's not one or the other. But if I have a patient that has a very hard time, I say, hey, look, with your ADHD, if we're not using medications, and if you don't have a pulled muscle, or if it doesn't hurt, I want you to get on the edge of your desk and set a timer every hour on the hour, stretch a little bit, and just do a couple incline push-ups against your desk. I said, what? I said, not to where you hurt. I need the blood flowing. I need the brain distracted. I need the body moving, the oxygen. What would we tell a kid? Get up, get your wiggles out. Same
Yeah.
thing.
Yeah.
We're just not going to walk down the hall and get our wiggles out at work. Well, I mean, I do,
I
but
mean, you could.
yeah.
And
But
so you're seeing that that's effective with your daughter?
oh, oh yes, not with
That's
just my
great.
daughter, but with my patients as well. What I often tell them is
Now,
I
are you
say,
seeing adults and children or,
I see 6 years old till end of life,
oh, wow.
all the
So
way
you
through.
are able to apply it
Yeah. So when our
full
body
spectrum.
is, yeah, when our body's craving that dopamine and it's got the norepinephrine, the transmitter issue with ADHD, I often say I'll often start with, what is 45 minutes of cardiovascular exercise a day? What does that sound like to you? They say horrible. I said, I know. That's what's in every textbook, and that's what we all say. What does 15 minutes sound like to you? I could do 15 every day, every single day. I said, in the sunshine with clear skies and birds chirping, all that stuff, I can do that. That would be nice. Can you do it in one direction and set a timer and then turn back? Oh, I can do that. Then they'll come back. You tricked me. I didn't trick you. I helped you trick your brain. You made me walk 30 minutes every day. I said, no, I didn't. You walked 15 one direction and turned back around.
Oh, that's great.
Yeah. And they
It
love
took
it.
me a little bit of time to understand. I was like,
Right.
ah,
But they're like, I've been walking 30 minutes every day, 15 one direction, 15 back. So with the brain, it says I've walked 15 minutes this way. I've gotten some sunshine, some cardiovascular stuff, my heart beating. And then I get a little antsy, but that's okay because I'm going home soon. So, okay, good. I'm about to go back to what I'm going to do.
and I
They
can do
still,
that chunk of time again.
that chunk of time again. Yeah.
I like
So there's your dopamine. It's all full. You can find dopamine reward in all of that. The cardiovascular aspect, the excitement that you succeeded in your goal of 15 minutes, not the 45. Also that, oh my gosh, I actually did 30. That's rewarding. And I don't care what it is. It can be 5 minutes. It doesn't matter. It
yeah.
just anything. Building habits is very difficult. and people can take their time.
Yeah, definitely. Um, Someone asked, so I guess kind of an intersection again, or maybe marijuana use and dopamine.
Yeah. So THC, it's very vague. My answer has to be chunked. So
Okay.
there's complete THC marijuana use, and there's the legal products in some states that are CBD based, but we can't separate metabolically. We cannot separate THC from CBD. So a lot of the CBD products will still have like 0.03% of THC. So when we use those products, the endocannabinoid system, which is fancy for just replace that with CBD, right? There's a lot of benefits to the body with that when it's regulated appropriately. However, what we see is that THC does a substantially rewarding job of calming down anxiety, increasing appetite, decreasing pain. However, it flips for a lot of patients to anxiety, paranoia. It depends. And a lot of that has to do with the prefrontal cortex of the brain. THC, when it does that binding in different parts of the brain, the prefrontal cortex of the brain, on average, 25 to 27 years old, that's when it's fully formed.
Okay.
So when it comes to the dopamine reward pathway, I get a little nervous with THC, and there's other reasons why. There is a lot of anxiety or depression disorders that have not reared their heads up to more expansive disorders like mood disorders until a certain age. And so THC can be very catastrophic in a bipolar depression population or a mood disorder population. It can induce mania, hypomania, or paranoia substantially in that population. And typically, we don't see those. It could be depression, anxiety. We typically don't see those breaks into like a hypomanic or manic state until like the ages of like 18 to 24, and again at like 26 to 34. There's what we call bimodal distribution, two spots where it shows up. And so I often see patients that will say, hey, you know, I've been using CBD products for focus, and then they got really expensive as like gummies. So a little marijuana or a CBD or a THC pen like Delta 8, Delta 9 has been working well. I'm like, you're 18, be careful. Let's talk about it a little more. Do you have any history of bipolar disorder in the family? Yes. Okay. There is some genetic predisposition. And I would say about 25% of the time, they come back and say, that flipped on me. I had a full blown panic attack. I had massive mood fluctuations. And about three or four of that out of that 25%, which is a low percentage, has
But
actually
I think that's a
triggered their,
huge percentage.
well, it's actually triggered their first manic episode, 3 or 4 days without sleep.
So if if someone, okay, I'm speaking about my family again. So we have bipolar, and so one of my sons smoking pot, exactly what you just described happened. Would that mean that that was a full-fledged mania? Therefore, he technically could have a bipolar diagnosis, or could it just have been induced
Yeah.
by marijuana and isolated?
Yes and no. So substance induced psychosis is a real thing.
Oh,
It,
yeah.
it,
The
it
ER
can,
is here. Yeah.
so let's give you a real simple example. We can give you prednisone. We can give you steroids and keep you awake on accident for days. But the steroids were incredibly important. And that's a very outlandish thing to say, like for days. It's very rare. But there are a
Okay.
lot of things that can do a substance-induced psychosis. A lot of different medications, a lot of different substances, um, and that is an isolated event. And we've seen that plenty of times where Delta 8, Delta 9, or the legal products or medicinal products have flipped, and then we've stopped those products. THC takes about 35 days to get out of the system on a drug screen, so it's a slow metabolizer. Things calm down. We initially treat that, because people want help. We treat that. And then 3 or 4 months go by and the dose is much lower. And it started at a low dose of something for bipolar disorder and it calms down. and they say, look, I haven't touched any marijuana in a while. Do you think it's safe for me to try a week without this? Sure. Sure. Come back and see us in 2 weeks or 3 weeks or 4 weeks, or walk in if it's a crisis, but start it back up. We have a plan. They stop it, and then they've been off of it for a year and nothing happens again.
Yeah.
And and then I've seen that plenty of times. So
Yeah.
brief psychotic episodes or substance induced psychosis, yes.
Yeah, because there is one person, gentleman I know that his son, his adult son, is as long as he stays away from marijuana, he's fine. But the
Yeah,
second he starts, and of course, he convinces himself he can keep starting, and instant psychosis.
yeah,
Um,
it's
ERs
it's
are
so sad.
flooded with cases. Um,
Yeah,
but is it because of the increased THC content? I mean, because this wasn't, I don't think this was a thing when
there
I was
there was
growing
some
up.
wild, yeah, there was some wild study I can't remember. So my quote is not going to be completely like statistically accurate, but 1970s versus what we have now, 17 to 20 times more potent,
Yeah,
especially
that's
yeah,
scary.
and so with the addiction medicine population, we're talking about, to use the terms that are used, schwag, bottom of the barrel stuff, is probably what was most helpful for anxiety and relaxing in the 70s. The stuff we have on the street now that are for purchase is going to be probably things that parents, grandparents never ever would have even thought about touching. And we can see that in some older patients that are like, I thought, in the 70s it worked. And I thought now that I have depression plus cancer. I have depression plus this. In states that it's not legal, we buy it from X, Y, and Z. I had the worst panic attack I've ever had in my life, David. Like, it was horrible. That is nothing like I remember. I can't biopsy your brain, and I don't have a microscope in a lab here to tell you, but
But if
we
I,
we could hypothesize that that's way different than what you had.
so then what if they still, let's say they still wanted to try that as a way to help, what would you say to them would be a safer way, a safer marijuana or THC to
Oh,
use? And I'm
that's
not
such
saying you're endorsing.
so it's very difficult because it is one of those things where
It's
this is not political, but I don't like a lot of hands in medicine that have a monetary tie, you know. But this is one where if there is a state, and in my state, North Carolina, we're not there, but if there is a place where it can be titrated and moved to a place where the levels of each kind of cannabinoid and THC are manipulated to treat such and such and such and such, that's fantastic. That's great. But I can't promise what you're getting is going to be helpful. Matter of fact, I can 100% promise that what you can get from a shop down the road for Delta and Delta 9 is still held in a suspension that we're going to vape that is probably not going to be good for your lungs, period. So I would recommend not doing it at all. However, I can also say it's not FDA approved, and in my state, I can't write it. I don't feel comfortable writing it, even if it was, until I see the data. But if you do go out of state and you wish to try X, Y, and Z, consult someone there that knows what they're talking about, not me.
fair enough.
That's what, and I said, and by all
Like the
means,
answer. I
be
mean, because
safe.
so many people talk about that, just the medicinal use of it. So I was,
It's look, it's I guarantee there are fantastic medicinal uses. But it's benefit versus risk, and I think everyone doesn't have to go in a deep dive, but everyone can use ClinMed or PubMed, what we use for current up-to-date research. And when you tease out some of the articles, you can go to the summary and the conclusion, and those have less giant words that even I don't understand half of. And it will
I
say
do.
out of 500 patients, uh, 2 found it helpful. You know, so I often tell people, go look it up. Not on WebMD. Go to PubMed where I go. Go to ClinMed. Yeah, go take a look at clinical update. You let me know what
decision.
other states are finding and make an educated guess for yourself. But I'm not endorsing it.
I like that though, encouraging your patients to educate themselves, not just take your word for it.
Yeah,
I
yeah.
think everybody should be doing that. So another line with dopamine, the excess and maybe causing troubles. I was thinking about once seeing the symptoms that could arise. I was thinking about my daughter's bipolar, um, her manias, and she had
Mhm.
psychotic episodes with her mania. So I never even thought about the excess that,
Yes.
those symptoms being an excess of dopamine. I had always thought, dopamine, good.
Yeah, I think the way we need to think about that is when we compare it to like anxiety and depressive disorders. We normally treat those with SSRIs or SNRIs, selective serotonin reuptake inhibitors, right?
Mhm.
The best way to look at that is say, hey, someone's got anxiety and depression and it has gotten worse over time, but where did it start? It started getting beat down like 3, 4 years ago, right? And it
Mhm.
just got beat down, and the diagnosis needs to be greater than 6 months of the symptoms to get that diagnosis. So serotonin can take a hit. The fight or flight hormones can take a hit for a while before it doesn't bounce back. And we end up with panic attacks that come for no reason. Like, why is this happening now?
Yeah.
Dopamine can take a flick, a very, very tiny one. So once again, work backwards, right? So if we use a very low dose, very mild dopaminergic, like antipsychotic, the lowest dose, and we hit dopamine, D3, D2, we barely touch those. We start seeing not instant, but fairly rapid relief of symptoms compared to starting an antidepressant. 4 to 6 weeks, we kind of see a 1 to 2 week turnaround with things such as ruminating thoughts. It's kind of like what I described as like ADHD at bedtime. Like, why is this not shutting up?
Yes.
Racing thoughts, tangential stuff, flight of ideas, becoming the life of a party, starting new businesses, and then afterwards, the crash. And so, dopamine in excess with mood disorders, and I hate to say this, but is sometimes a lot easier for me to treat than depression and anxiety.
Ah, really?
You just nudge it a little bit.
Just give it a little bit. Well, and it did happen, the subsequent manias when she would go off her medicine, when she would go off the antipsychotic.
And that's when
So,
we see a lot of addictive behavior. So, in the world that I work in, when what we used to think was, oh, people use heroin because they got hurt and then someone overprescribed Vicodin and they couldn't get anymore, so they use heroin. I actually rarely ever see that. What I see is when I was a kid, I had this going on. Pick the PTSD side, pick this side, whatever. And then I self-medicated with this, and then it turned into this, and oops, it was laced with fentanyl. Oh no.
yeah.
And now you have it. Or I see patients that will say, when I use heroin or fentanyl, I don't get tired. I don't get constipated. I don't get upset. I actually become very normal. Okay, that's interesting. We detox, we end up in what's called a SAOP program, substance abuse intensive outpatient, and that's kind of calming down. And then we have another session, things are good. They go talk to the therapist for longer, and uh-oh, what's happening? They're acting a little euphoric in class. Now, I'm not worried about the euphoria if we see folks that often. The euphoria can lead to things that where someone feels like they're the life of the party and they make more friends. That's great. It can also lead to like a low level would be starting 3 businesses and taking all your money, all the
Yep.
way to very high risk behavior.
Mhm.
I'm worried about the bottoms. So when dopamine influx is up here and it's going wild, and we have manic episodes, and let's say regular sadness is down here and depression, mild depression's here. Well, if we're a little euphoric and having a great day and a great week, but then something bad happens, the distance between the two is this, right? This far.
Okay.
When we have mania up here, but we keep the regular sad stuff down here, when the mania stops, the distance is greater. So I'm more worried about the suicidality that comes. after the manic episode. That's what I'm trying to help prevent. So we're
Yeah,
treating the highs so the drop isn't so severe.
yeah, that makes sense.
Yeah.
Wow. Oh, yeah, that was very educating. So thank you. I
You
like
know,
that. And also the visual, even with the hands, I was like, okay,
that's what I do.
I
A
see
sheet of
that.
paper. I'm like, I'm
Yeah,
okay with sadness. When people die, you should
yeah,
cry. You should cry and you can mourn for as long as you want. We'll talk about it. If you're elated and you want to go start a business and you've got the capital to do it, or you don't, you want to fundraise, go do it. If it gets out of control and if it goes like this, like a yo-yo, and it's impairing your life, talk to me first. Please, let's talk about, and then you can pick it. We used heroin, but let's talk about the binge eating you do when it goes like a yo-yo. You don't have to have a bipolar diagnosis to have some mood swings. You could just have life happen, and life induces mood swings because life is life.
yeah, yeah. It's
People are
crazy.
grasping at dopamine, and it's very natural to do that.
Yeah, we just need it to be occurring naturally in healthy ways.
Yep.
Um, okay, so what are not medical advice, but what are current medical trends with regards to dopamine?
So yeah, we start with the lifestyle modifications. I'm a very big fan of lifestyle modifications, but I am not a fan of asking people to do things quickly. So the cardiovascular exercise thing I mentioned, my mother lost 80, 90 pounds in 3 years doing this thing, precision nutrition. Like I said, it's not that, but it is based off of building a habit. So very successful. It's a great metaphor. This month, I want you to drink 6 glasses of water a day. Next month, I want you to do 6 glasses of water. Plus, let's try your hardest to only have one snack a day that comes in a bag. Not a Ziploc bag, but a bag, like what you have to peel.
Yeah,
All right, keep that for 4 months. So that worked really well for like the binge eating and the weight side. But when it comes to keeping the lifestyle stuff in check, baby steps, very, very small baby steps. That way, when life comes in, and I always use this morose realities, but very bad, horrible consequences of life. Let's say you got in a giant car crash and you just started running 3 miles a day, and that's your fix. But now you can't walk it, you can't run at all. You can still do the 15 minutes a day. So that's the analogies, baby steps. In terms of medicine, when we're dealing with addiction, we do need to work, medication assisted therapy, regardless of what people think. It's incredibly well documented and clinically evident for addiction, for opiates. So that would be buprenorphine, Suboxone. For alcohol, that would be more of the naltrexone realm or the Vivitrol realm. It decreases the cravings. This is a risk benefit. This is risk mitigation so that the cravings are dropped and we can go to the underlying cause. You work on the lifestyle, we'll block the receptor and help you get past that receptor issue in the brain. And then let's talk about what you talked to your therapist about: childhood, ADHD, depression, anxiety, losing a job. Let's talk about what really came first before all of this,
yeah.
and then treat that.
But then what, when you, for someone who's trying to withdraw or, stop painkillers, and then you said the Suboxone, like how long then is someone on that? Because you're replacing it with another drug. I
Yeah,
mean, so then is there, a plan to eventually stop that? Because I hear about just people being on that
sure.
then for
If they
so,
want to. It's a really bad metaphor, and the medical community might get a little frustrated with it. But if we have type 2 diabetes and we don't get things under control in time, are we going to stop metformin or Wegovy or Ozempic or any of the new favorite GLP-1s? Are we going to stop them? No. So it is a tailored approach to that person. It really is. So I know what's in Suboxone. I don't know what you're getting off the street. I have no idea what's in it.
okay.
That's
And
the point.
that tailored.
So even after we're done tonight, I will be rounding on a facility-based crisis, and folks will come in for that detox. And I thought I was doing this, and it's got fentanyl in it, and trank in it, and Xanax in it, and what's in Suboxone is buprenorphine and naloxone. Naloxone is a blocker, kind of like Narcan,
Mhm.
same compound, and the Suboxone. So what we're doing is we're binding a receptor site for cravings while we do group therapy. Intensive group therapy is what we should be doing. Regular intensive group therapy. Here we do, it starts out 3 hours, 3 days a week. And Suboxone is like 7 days, 5 days at a time.
Wonder if
And
that's happening at all the clinics. I mean, is
um
that standard?
it's
Should be standard.
it's clinically recommended on SAMHSA and ASAM.
Yeah,
So
that's
yeah,
correct.
yeah. But when we do that, it allows us time to build those habits. It's not the best metaphor, but it goes back to the diabetes metaphor. I'm sorry your A1C and your glucose got to this point and you gained the weight. We need to get that under control because the ramifications are dire. Think
Yeah,
about diabetes, foot amputations, etc. Think about opiates, overdose, death, all
yeah.
the above. Let's get this under control. Let's start the lifestyle modification changes. Let's get you in contact with this person, and let's.
Whole
Have you
treatment.
ever? How long's this depression been there? How long?
Yeah.
Have you ever been on Zoloft? Even a baby dose, even the pediatric dose. Are you afraid of it? Let's talk about it. Have we? Let's talk about these other. It's not just Zoloft. It's just have you ever been on any antidepressant? Have you ever been on anything for mood? And you don't have to be on that forever either. But we've got to treat the underlying cause.
So then, while we're wrapping up the destigmatization,
Oh
what,
yeah.
yeah, talk to me.
So the best example I have for you of that is about 10 years ago. I was surfing in Ireland, and all the pubs, like people are like, "Oh, you went to a pub?" Well, that's also where you get food. And in the restrooms in our country, there's scratches of hateful things. 10 years ago, there's a big circle in the middle that said Good Samaritan. There was a 24/7 phone number. It said, "Are you drinking for any other reasons? Call the Good Samaritans."
I love that.
I'm not bashing where we are, but mental health is an epidemic. The destigmatization is love or hate social media. I go back and forth. One of the good things that's coming out is the multitude of resources and stories and testimonies about normalizing the
The
human body,
conversation.
and what happens to it. From what I often tell people when I talk to like friends in the pastor world, and not making it spiritual, we will gladly take a Tums if our stomach is hurt. If our back hurts, we'll take an ibuprofen. We have a muscle and a hollow organ, the most complex organ in the entire body, which we rarely can biopsy. We can scan, we can look at, gets sick. We're not going to treat it.
Exactly.
Or was it always sick? Or can we at least try to put a band-aid on it?
Yeah.
Um,
Can we
then how
investigate further?
Okay, yeah, exactly. And I'm seeing a lot more of the baby boomer population and the Vietnam era population come into the office for the first time, grown men that so we never did this. And
Oh,
they're like, I think the days of not talking about it are over. And
I,
it's
I love
amazing.
that. I bet
I,
that's powerful to
oh, it's like
witness.
one of the things I tell them is, I was like, good. Do you know how many lives you're going to actually save just by actually coming in here? It's generational.
Yeah, and then
You're
could you imagine if you actually shared with another person that you came in, you know? I mean, kudos for walking in and talking about it, but it's the minute you share it with other people, then it just is amplified. And that, stigma is something with everything that we do at NAMI and NAMI
Yeah.
Coastal specifically, it is just trying to help decrease the stigma, just normalizing the conversation. I appreciate you speaking with me tonight and thank you for all the information. We will be, this is recorded, so eventually, I can't, we're a whole lot of volunteers at NAMI Coastal, but
Yeah.
eventually it will get posted on our website. And when it does, I'll be sure to share the link with you and we'll post it on our social media as well. But I thank you for your time.
You're
Thank you
welcome.
for everyone who watched us on Facebook and for those of you who joined us on the Zoom. Thank you for your time.
And I
And
hope it helps somebody.
I'm sure you did. I'm going to say, yes, you did. Well, you already helped me. So thank you.
Good.
I
You're
appreciate it.
welcome.
It was nice
Thank you
meeting
all
you.
so much.
And we got a thank you in the chat. Thank you.
Thanks.
Have a good
All right.
evening.
You too.